Well, I wish to have an answer for this actually, because if I had the answer, I would have a Nobel Prize by now. Because usually, unfortunately, with no matter techniques and advances in science, we still are not able to pinpoint exactly why it didn't work despite good quality embryos. Now, the good quality embryos is depending on what. It used to be like under the microscope. Are you talking about just from embryology point of view? Yes, we have a scoring system. Yes, we have like a grading of the blastocysts, and everything looks fine. However, now we are more kind of classifying things, how could go wrong or what could go wrong, into three basic categories. One is genetically, are we talking about anything genetically happening with the actual embryo? The only way to address this is to have a biopsy. And if you have heard about the PGS or now the PGTA, this is mainly to address this question. Despite good quality embryos, they could be chromosomally abnormal. Why? Because it doesn't match with the actual shape of the embryo. You can have a very good quality under the microscope and still genetically or chromosomally is abnormal. And the other way around, you can have a rather not as good quality embryo as you could think under the microscope. However, it is completely chromosomally normal and no problem with it. So the only way to address this would be through a PGTA. The second main element is the implantation of the embryos. Okay, is we are trying to have advances in this field as much as we can, and you've heard about the ERA testing, for example, like endometrial receptivity testing. As you know, by the consensus for implanting an embryo, we administer like progesterone for 5 days or 6 days during a blastocyst, and this is arbitrary. Unfortunately, we don't know exactly what is the best time or how long should we give progesterone for, but we know that there is a implantation window, and we try to hit this window with 5 days or 6 days of progesterone. However, there are patients who have pre or post implantation window, and this where this endometrial receptivity testing has come up to address this answer. Some people need more progesterone, like maybe 6-7 days or 8 days of progesterone. Some people have or need less progesterone basically rather than 5 days. Unlikely, because the majority of the patients are post implantation window. Okay, so this is the second thing. So we said genetics and then implantation. Now the third one is the immunology. As you can guess, if like people like talking about, is there any immunological factor that could have impacted the issues of implantation? So there is a huge debate and argument and evidence-based and not evidence-based. So I can get you like the two sides of the coin. You can have like, yes, there are some straightforward conditions that definitely needs attention immunologically, such as rheumatoid, systemic lupus. We know that there is an impact on the immunological factor, and these are the most like evidence-based to supplement steroids, for example, or low molecular weight heparins. However, other conditions are still not evidence-based, but some clinics obviously offer immunological modulation or treatment in order to overcome simple immunological derangements. And when I talk about that, I'm talking about if you heard about the natural killer cells and the cytokines and all these issues. So I'm not going into details in that. However, this could be, yes, it could be a reason why good embryos would not implant. And the fourth one, which is obvious, is nature. Like no matter what you do, despite like you have everything in good shape, whether like genetically normal, no immune problems. Implantation happen like like straightforward. However, you cannot beat nature because nature has its own agenda. You have a specific percentage that you cannot exceed. I cannot have 100 couples who started IVF or natural pregnancy, and then I end up with 100% pregnancy rate success. This doesn't, it defies nature because there is somehow a natural selection, and what is allowed and what is not allowed to exceed. It's beyond our sort of capacity. So no matter what advances we are going to achieve, I don't think we will reach a stage where we say like 100% means every single embryo transfer will end up by a pregnancy. Unfortunately, this is not achievable. However, the main advantage now of a successful IVF treatment is to have good number of eggs who fertilized, reaching blastocyst stage, in order to allow me to transfer one or two embryos and cryopreserve the rest. If this is the scenario, you have a successful IVF treatment. Even if it doesn't work at the fresh transfer, for example, there are cryopreserved embryos that can be used. And this is why now the successful pregnancy is now built on not only the fresh transfer, but the cumulative success rate of a fresh and a frozen embryo. So if someone has one and then another one or two, and then even she got pregnant with the second embryo transfer, is still considered as a successful pregnancy, as a successful outcome from an IVF treatment. So this is the main thing. I don't want you to be disheartened, like if it didn't work from the fresh cycle, okay? It's bound to, to not work sometimes. So if we have an extra embryos which are cryopreserved, that's the main asset for you, the main asset that we can use one, twice, or whatever. So, and they are cryopreserved for 10 years. So this is the luxury to have the treatment within this period of time. Once you are pregnant, we can say that you had a successful outcome. So it can be delayed, but eventually it will happen.